are really sort of presented by how many people are here today to support her. And I know she's got family. She has her faculty from across the university here. She has her colleagues both in the doctoral program across the campus and also in the Cancer Center from the research teams that she's a part of. Tamryn earned her bachelor's in nursing and her master's in nursing education and leadership from the University of North Carolina at Chapel Hill. She served as a certified oncology and bone marrow transplant nurse at Duke Hospital and was also a clinical faculty member at UNC Chapel Hill. Tamryn is a Robert Wood Johnson Future of Nursing Scholar. This requires her to complete her Ph.D. in a record 3 years, which brings us to today. During her rapid 3 years here at Hopkins, Tamryn has been very productive. She's co-authored multiple manuscripts, presented nationally and internationally, and has received numerous grants, scholarships, and awards. In addition to being a valuable member of multiple research teams on the campus, Tamryn has contributed to the teaching mission here at the School of Nursing and has also been very active in student organizations across our campus. Tamryn remains just as excited and energetic and enthusiastic about her research as she did the day that she first came to Hopkins to interview. And at that time, we talked about our mutual interest in clinical trial decision-making and the importance of family. Family is very important to Tamryn, as you can see. I'm so pleased that she has the opportunity to share the results of her work with you today in her presentation, Decision Partner Involvement in Cancer Clinical Trial Participation.
Thank you, Dr. Wenzel, for that warm introduction. And thank you all so much for being here today as I share my findings from my dissertation study on decision partner involvement in cancer clinical trial participation. So similar to a GPS, this slide will give us some direction as to where we're going today. First, I'll be talking about background and gaps in literature, followed by the study purpose, aims, and methods. Then I'll be sharing the results from my quantitative and qualitative phase. And I'll close with the summary findings and implications, and then open up for questions. So just a bit of background. 1.7 million new cancer cases are expected to be diagnosed this year. Moreover, older adults currently make up the largest segment of the cancer population. According to the American Cancer Society, 87% of all cancers in the U.S. are diagnosed in people 50 or older. Additionally, cancer remains the second leading cause of death in the United States, second only to heart disease. That's about 1,700 deaths per day. So there's good news. There have been some steady improvements made in cancer survival rates since the mid-1970s, largely due to clinical trials. So for this presentation, when I use the word clinical trials, I'm referring to therapeutic cancer clinical trials, which are treatments that are under investigation to see if it works better than existing therapies. Clinical trials offer patients access to new treatment modalities that they wouldn't otherwise have access to. In other diseases, patients may participate in clinical trials for altruistic reasons, to help others. But cancer patients oftentimes participate in clinical trials in order to actually seek remission and cure. So although clinical trials are instrumental to advancing cancer care, less than 5% of adults with cancer are actually enrolled in clinical trials. These rates are especially low among women and minorities. So you may be thinking, why should we care? Why does it matter that people are not enrolling in these trials? This matters because these low participation rates delay the progress of new cancer therapies, as well as delay efforts to reduce cancer health disparities, since there's often inadequate representation of minorities in these clinical trials. So we already know from the literature that there are existing barriers to participation, such as strict eligibility guidelines, extra tests, time, and travel for patients, to name a few. This slide focuses on the decision-making process. How do patients get to a decision about participation after weighing the benefits and risk? When a clinical trial is available and offered to patients, it complicates treatment decision making for them because it then becomes one of the many options for patients to choose from. And although clinical trials are voluntary, it still represents a decision that patients have to make. And some patients may feel underprepared to make this decision, and this is because there are high-stake consequences and unknown risk. There's a lot of uncertainty in the outcome. So in shifting a bit, in healthcare, we recognize patients, we respect patients' rights to make decisions, honoring their autonomy. But in doing so, we often ignore that family or friends may be involved in decision making. Behind the scenes, that's the principle of relational autonomy. Relational autonomy recognizes that patients are individual as well as social beings in decision making. So in this study, family or friends will act as decision partners as they play a role in decision making. And preferences for decision partner involvement in decision making may vary from patient to patient. I'm not presenting it here, but we also did a concept analysis on the term decision partner, where we defined and described decision partner in more depth. So many studies have looked at cancer treatment decision making very broadly, and many family-related research have looked at pediatric populations in cancer involving parents. And also, many family studies are conducted outside of the U.S., which can limit the generalizability of their findings. To our knowledge, evidence is lacking regarding how decision partners influence choices, how they're involved, and whether patients even prefer to involve them in clinical trial decisions. So in an effort to contribute to this area of research, we conducted an exploratory descriptive mixed method study to investigate how individual patient factors such as race, age, gender, ethnicity, marital status, education, and patient preferences for involvement for decision partner involvement may relate to clinical trial participation. So this study consists of two phases. We use an explanatory sequential mixed methods design. I'll first be presenting the quantitative phase, followed by the qualitative phase, and then discussing integrated findings. The first phase includes an analysis of a baseline data obtained from an ongoing parent study, and the second phase consists of semi-structured interviews with a proposed sample. We used two different frameworks to develop a conceptual model to guide our study. First, we modified the decision-making ecology framework as well as the model of cancer clinical trial decision-making. And this conceptual model posits that there are many factors that combine to influence a decision or an outcome. In this case, the outcome is the decision to participate in a clinical trial. We wanted to see relationships between individual patient factors and how it related to clinical trial participation. We also wanted to see if clinical trial knowledge, attitudes, and beliefs moderated or changed that relationship. And for this study, clinical trial knowledge, attitudes, and beliefs is a single construct. So it'll be kind of measured as one big piece. We also wanted to look to see if case-specific factors affected clinical trial participation. And case-specific factors are unique to the case of the patient, that they can't necessarily change, like their cancer diagnosis, if they've been offered a clinical trial, if they have prior clinical trial experience. We also added in decision partners into the model, where we wanted to explore interpersonal influences that decision partners had on decision making. Our first specific aim was to describe relationships between patient factors, clinical trial knowledge, attitudes, and beliefs, which I'll shorten by saying CTCAP, and clinical trial participation. This was the quantitative aim. And we set out to test 4 hypotheses. First, we hypothesized that individual patient factors are associated with clinical trial participation. More specifically, lower education attainment will be associated with decreased participation, and younger age will be positively associated with participation. We also hypothesized that clinical trial knowledge, attitudes, and beliefs will be associated with clinical trial participation. An increase in CTCAP will be positively associated with participation. We were unable to conduct hypothesis testing for hypotheses 1.3 and 1.4 due to not having enough data about decision control preferences reported. The second aim was to explore the process of decision making about clinical trial participation among persons with high levels of decision control preferences and those with a more deferred style. And high levels of decision control mean those individuals who really didn't want to involve decision partners at all. They wanted a high level of decision control. And those with a more deferred style wanted to have some sort of involvement of their decision partners. And that was our qualitative aim. So the dissertation study was a nested study within a parent study entitled Impact Patient Navigation. And this study was a randomized controlled trial examining the effectiveness of a patient navigation program. And it is still active and ongoing. And so we use convenient sampling to recruit participants from the parent study to our study. So the study site and inclusion criteria define the pool of patients available for our study. We recruited patients from Johns Hopkins Hospital, Sidney Kimmel Comprehensive Cancer Center, and participants had to be 18 years or older, have a primary solid tumor cancer diagnosis, have an identified clinical trial through a screening algorithm, and a resident of Maryland. All participants were newly diagnosed or new referral patients to Hopkins. So this slide here provides an idea of what was part of the parent study and what was part of the dissertation study. It also describes the variables that we used from the parent study for our study. So on the top, you can see on this row here that we used CT cap, education level, marital status, and cancer type, and decision about clinical trial participation from the parent study for our study. You can read here kind of what these variables were about. I'll just focus on this one. So CTCAP was an 18-item survey that measures knowledge, attitudes, and beliefs about clinical trials. The higher the score means that individuals had more knowledge and more positive beliefs and attitudes about clinical trials. And the highest possible score was a 90 that individuals could have. The Cronbach Alpha was 0.66, and the parent study is still continuing psychometric testing on this survey. We added in demographic factors for the decision partner, you can see here in blue, and we also added in decision control preferences as a variable. And decision control preferences, as shared earlier, really looks at patient preferences for involving decision partners in decision making. The score can range from 1 to 5. 1 meaning the patient had a high level of decision control, not wanting to involve the decision partner at all. 2 means that the participant wanted to make the final decision after input from the decision partner. 3 means that they wanted to share equal responsibility in decision making with their decision partner. 4 means that they wanted to have the decision partner make the final decision after input of the patient. And then finally, score 5 means that they wanted to defer all of the decision to the decision partner without the participant being involved at all, the patient being involved at all. So for the sake of this study, I'll be collapsing high DCP, I'll be calling it high DCP, which is wanting a high level of control, no decision partner involvement, as kind of 1. I'll call it 1. And then deferred style between 2 and 5. We performed descriptive statistics and conducted t-tests and one-way ANOVAs, as well as chi-square tests and Fisher's exact test as appropriate. As described in previous slides, our main outcome variable was clinical trial participation. We had already performed an a priori power analysis to ensure that our study would be adequately powered that resulted in needing a sample size of 76 to detect 80% power with a medium effect size. Due to the unexpectedly low number of individuals who were offered a clinical trial, we were not able to perform logistic regression like we had intended, with only 25% of our sample actually being offered a clinical trial. So hence, we performed exploratory analyses with multiple linear regression using CTCAP as a dependent variable to really just investigate possible predictors of this variable. We conducted a post hoc power analysis for the sample of 80 participants who had completed the CTCAP assessment and found that for a medium effect size, for 80%, we needed 76 participants for 80% power. So we felt comfortable performing this linear regression. We used 95% confidence intervals to help see if the results were significant or not. So who were these individuals? So a total of 82 participants were included in the study. As you can see, the mean age was about 60. We had slightly more males than females, and 46 of our sample were non-white, mostly married, and 18% of the individuals had a high school graduate degree or below. 61% of the individuals had some college if not a bachelor's and a graduate degree. But surprisingly, 20% of our sample did not report education. So we're not able to provide much more information about those individuals. And the majority of our patients were prostate and breast cancer patients. And as mentioned, 25% of the individuals were offered a clinical trial. So this just shows a quick breakdown. I won't read all of it, but I will just point to the option here where individuals, 38% of the quantitative sample who reported the decision control preference data preferred to make the final decision about treatment after considering the input of decision partners. And I forgot to mention earlier, but when we were looking at decision control preferences, I was also curious as to whether, if you compare decision partners with physician input, as the literature already shares, physicians have such a big role, I wanted to know how do they stack up against one another. So this subcomponent of that scale actually looked at comparing physicians to decision partners. And overwhelmingly, 62% said the doctors had input weighed most heavily. And this is just a quick description of what do we ask individuals when we are measuring knowledge, attitudes, and beliefs. I won't read all of it, but I do want to mention that 68% of the individuals said that agreed or strongly disagreed that they would trust their doctor and participate in a clinical trial if he or she recommended. Surprisingly, 10% of the individuals had only participated in a clinical trial, and not many people knew anyone who had participated before. But even with the case, people really didn't find clinical trials as frightening. So this slide here just really shows who is this mysterious 61 individuals who weren't offered? Were they different from the others who were? And when we looked at mean age in our one-way ANOVA test, we found no group differences in mean age. So in our bivariate analysis, none of the factors examined were statistically significant when looking at associations with participation in clinical trial. And that could be that we could not detect statistical significance due to the low number of individuals who were offered. Nonetheless, we did notice some trends that we will share here. As you can see, when offered a clinical trial to 21 individuals, men were more likely to say yes than no when you look across the row. And when you look here, females when offered were equally likely to say yes or no. I wanted to also point out with race, when we combined when we compared white versus non-white participants, there were equal proportions if you look across the row, with people saying yes and no. And sometimes in the literature it says that non-white participants are just automatically going to say no. So this is a great piece of data to really share against those findings. And I also wanted to share down at the bottom here, no surprise, people who scored higher in CT-CAP, the higher score, so they had more knowledge, more positive beliefs, overwhelmingly said yes when offered a clinical trial. So this is just a quick slide to show associations between different variables. I'll just point out two things here. You can see there's a strong association with age and race, as well as a strong association, positive association with CT-CAP and education levels. And this really helped us decide what do we put in our multiple linear regression. So when we did the exploratory analysis with CT-CAP, we found that these were all strong predictors, identified as strong predictors of CT-CAP. So race, gender, and education, even after controlling for covariates. So as an example, when you compare non-white to white participants, you can see there's an increased score by almost 4 points on that survey. And when you look at females versus males, males had a score about 4 points less than females. So that means females tended to have more knowledge and be more positive about CTAP, about clinical trials. And those with a high school education and below compared to some college or higher, those with some college or higher had a higher, had more knowledge and more positive attitudes and beliefs about clinical trials. So for our second phase, the qualitative phase, we wanted to explore the process of decision-making about clinical trial participation among persons with high levels of decision control compared to those with a more deferred style. And we used purposive sampling to select our patients. Those individuals who had completed the decision control preferences scale were included in the interview. We interviewed patients and decision partners. Not everyone identified a decision partner, which is part of the point. We don't expect everyone to have the same decision control preference, but we wanted to get a variety of perspectives. And as shared earlier, we also collected demographic information on the decision partners. And we obtained oral consent for all of the participants for our study. A semi-structured interview guide was developed by the study team based on available literature, clinical experiences, and expert review. And we used a phenomenological approach to understand the following topics here at the bottom. We really wanted to start broad with understanding their experiences with cancer. I am pointing to something invisible. And then we're narrowing it down to what does the decision partner do in that role. So data collection occurred in a 4-month period, and the interview dates and times and locations were negotiated based on the convenience of the participant. Interviews were about 25 minutes, and they were either in person, telephone, or by video. And the interview types they really range from individual interviews, dyad interviews, or separate interviews with the other person present, based on their comfort level. And each participant was financially compensated and received a hospital parking voucher. The aim was analyzed through thematic analyses to describe the process of decision making about clinical trial participation among individuals with varying levels of decision control preferences. Interviews were audio recorded and professionally transcribed verbatim. There was simultaneous data collection and analyses that occurred, and me and a second coder, we read and reread the transcripts line by line to ensure reliability in coding. The coders met frequently to discuss and compare codes as we did them individually in order to inductively identify themes and establish themes that we'll use for the results. The phrases and passages were coded to look at meaning, structure, and really the essence of the lived experience for those individuals in the topics that I shared earlier. After searching for commonalities among individuals, we were able to identify themes. And we used an audit trail to really explain kind of how we track those codes and categories. So who are these individuals in the qualitative? We had a final data set of 24 individuals, 12 patients and 12 decision partners. So you can see here, you can see here that the mean age for patients, the 12 patients, was 59. And we had slightly more females than males. We had a great variety according to race. Majority were married. And we also had a mixture of people who were offered a clinical trial at that baseline data collection and those who were not. Delayed offer means that those individuals were offered a clinical trial but won't start the clinical trial until after some sort of standard therapy like radiation or chemo. So it wasn't going to happen right away. Decision partners, they were slightly younger, mean age of 53, and we had equal numbers of males and females. And most of them were spouses of the patients. We had a great variety and dispersion of race. And interestingly, many of the decision partners had careers in healthcare and research.
Right. Drink coffee on that one.
Yeah.
Wow.
And we did describe, in our sample, we had a good variety of individuals with decision control preferences that really spanned. You can see the majority of the individuals prefer to make that final decision after the input of decision partners. And this shares kind of what they thought about physician input versus decision partner input. And all these come from the quantitative phase to give you an idea of who these people are. So most people, again, had the doctor's input being the most heavily weighted. So the results from the thematic analysis led to 4 distinct themes. And this slide provides an overview of the qualitative findings on our specific aim as we look to understand the process of decision making about clinical trial participation for those with varying degree decision control preferences. You can see the first theme is having the freedom to choose. So we'll start there. So many of the participants explained that when thinking about clinical trials, there was this sense of having the freedom to choose. They knew that this wasn't their only option. They knew that they could decide about other options regarding treatment. But we also learned in the interviews, when you have that sense of freedom, there's a confidence that has to come with it because you don't know what's going to result in participating in a clinical trial. And patients also talked about how they knew that they could go anywhere in the state. These were residents of Maryland. They could, as they were thinking about clinical trial participation, they wanted to know, is it close to my house? Is it far away? Are these the best doctors? So they had choices. And like one person says, one decision partner says, it's like choose your own adventure, right? If you go down this road, what happens? And then another quote here talks about maintaining a sense of autonomy. Although people have varying levels of decision control preferences, it was still repeated over and over again by patients and decision partners to maintain some sort of sense of autonomy in this process. So one decision partner says about his wife, who was offered a clinical trial, as I've told her many times, I'm not going through it. It's not my body. I certainly have an opinion about it, and I'm willing to share that, but the decision has to be yours. And what that is, we'll stand by it together. So the next theme is getting the most insight about clinical trials. Individuals, when they had decision partners present or not, they felt that it was important to really learn as much as they could about this. This is a topic that is really complex, and sometimes you just need to talk to different sources, talk to different providers, to get different perspectives. Most of them didn't rely on just one health professional before they made a decision. And they thought it was also important to talk with people who have gone through a clinical trial or people who have a research and medical background. So their decision partners may have been present, but they still wanted to talk to individuals who had a little more insight. So one person says, I'd definitely like to know if somebody else has been through it before. I mean, because there is something that I feel like is not as tried and true, I guess I should say. So I'm open to them, but I'm very hesitant because I feel like unless I know someone who's been through it and has come out of it on the other side, I feel like it's a little riskier. And she was offered a clinical trial and turned it down. The last theme is building relationships. Because it is risky and unpredictable, it's important, bless you, to build relationships in that, and trust in someone in that process. And overwhelmingly, as we saw in the quantitative themes, that having that partnership with the provider, not necessarily the oncologist, it could be your primary care provider, in talking about clinical trials, that was still important regardless if they had decision partners. And having network and access to people, so many people, patients and decision partners, described that decision partners were good sounding boards. And this is a quote here, he was a good sounding board to have for that decision. Because the primary person that I've spoke to, but he's the primary person that I've spoken to about it other than my doctors. And this patient here, he had a high level of decision control, and you can really feel it in the interviews. He had a family, but he didn't want to really involve anyone else with his prostate cancer. And he said, in all candidness, when I asked him about, would it be helpful to talk to the research team when he made the decision? He said, in all candidness, no. Because my thought is, if they are the research team, then they have a vested interest in it. I would think that if I needed medical advice per se, I would get that advice from my primary care physician. And what's outside of this quote is, he would talk to his primary care physician about a clinical trial, not just about medicine work generally, because he had a relationship with her. And realizing readiness was also important when making a decision. Not everyone was ready to make that decision about clinical trials. Some people hadn't even gotten over their diagnosis. So it's really unique to the individual, that process. You have to be emotionally ready. One patient who had been offered a clinical trial and said no, but she wasn't sure that she had been offered, but she was. She said, I'm not even sure what clinical trials are. I'm not sure. Sometimes my thoughts and stuff is not that, so I'm clear and stuff. And so a lot of times, and sometimes, I'm not sure what they're asking or what's saying. And then over here, we talk about the importance of, when you're making a decision about clinical trials, it's important to really think about the context and the cancer type and disease progression that the individual has. People often think of clinical trials as a last resort, so they often thought they weren't sick enough to think about it. One person says, I think it depends on the type of cancer you have. It really does. I think you definitely need to get into it when you have tried the normal things and they're not working anymore. So to integrate these findings, focus on the first column here. these are commonalities that I found with the quantitative and the qualitative. In both, you can see different examples from quantitative and qualitative findings, but in both of the phases, I found that the provider still has an important role in clinical trial decision making, even when the decision partner is present. And I also found that many participants prefer to engage their decision partners as well as their providers in that decision making process. And then lastly, many participants did not have much experience or exposure to clinical trials. So the big take-home points for this study is really there are barriers that still exist. We had 25% of individuals who were not offered. Knowledge, attitudes, and beliefs about clinical trials vary among individuals, which really saw there's different variables that play a role with that in terms of education and gender and race. And then decision partners, patients, and providers are all engaged at varying levels. So there were some limitations. We had methodological constraints using the parent study. I'm sure there may have been other variables that we could have included. There was a limited number offered at clinical trial. We were a single site, and it was cross-sectional, so we weren't able to make causal inferences. This was a highly educated sample, and we had some missing data in direct to internal consistency, and the social desirability bias. When people interview with patients and decision partners, they may have a tendency to not say the whole truth. But there were a lot of strengths. This was a mixed methods design guided by a conceptual model, and the interviews included multiple perspectives. We had a diverse study sample, and the quantitative and qualitative populations were very similar. We had minimal attrition with less than 5% dropout rate, and we also developed a concept for decision partners. And in practice, it's important to consider the patient's preferences for involving decision partners, as well as address barriers and disparities to participation. And importantly, researchers and clinicians should establish trust and relationship with patients and decision partners. There's a lot of research that's still left to do in this area. We should continue to evaluate the benefits of having decision partners. Does it decrease cost? Does it increase retention? We should also look at variations in decision control preferences. Does it change over time? Can we get more multiple perspectives in there? Can we incorporate stated preference methods? Thinking about the idea of what people value may determine how they make decisions. And importantly, create culturally relevant interventions based on decision control preferences. And that means different races may prefer to involve families differently. So we should make sure that we address that when we are including patients in decision making. And then finally, integrating decision partners within healthcare systems. These are the constant. People who participate in clinical trials go back to standard therapy, chemotherapy, radiation. The decision partners are there, so we need policies in place to involve them, as well as make sure that information about clinical trials is accessible to people regardless if they have a health background or not. So I'd like to thank my funding support for this work. And I'd like to thank my dissertation committee. This committee is one in a million. There's not a lot of people who will wear skates with you as you do this work. And I'm so grateful for everything that they've done, meeting with me on busy days, snow days, sick days. Each of them has contributed a lot to this study and invested in me as I've grown as a researcher. So thank you all. And thank you to my community here. There are a lot of people that were a part of this. I'd like to thank the parent study team members for allowing me and entrusting me with this data, the study participants and the clinic staff who made it just a little easier to get the work done. I'd like to thank Dr. Sarah Allgood for being a part of the qualitative analysis process, as well as the support from fellow Ph.D. students and faculty and staff. I've also gained a lot of different perspectives from my colleagues in the School of Medicine, Public Health, and the Bioethics Center. I'd like to thank my former mentors and former patients. They were the reason why I did this. I loved what I was doing, but they inspired me to look at things differently. And finally, my family and friends who have been there for me the whole way. You can wave. And it doesn't make any sense to study family involvement if they're not here, and my husband Kevin for being my rock. Thank you.
Well, you know, I'm easy, so I let you go. But